I'm going to control the slides while Jessie does the talk. So you will hear her saying, please change the slide. That's for me. Okay, thank you very much, and you can go for it.
Okay, so my name's Jessie Hayes. Like Dr. Santon said, I'm one of the Rahima ComServes at the moment, and I'm going to be doing a talk on hyperkalemia and looking at the management of hyperkalemia. So just before we start, to just change the slide, next slide. The definition of hyperkalemia is a potassium of more than 5.5. It's one of the most commonly affected ions in sick children, and we'll go into why. There is a range in children and infants that is age dependent, but we use more than 5.5 as a usual, as a benchmark. Hyperkalemia can result in a cardiac dysrhythmia that can ultimately result in cardiac failure. We do have some protective mechanisms against hyperkalemia, which we'll go into in the next slides. You can go next. Okay, so just looking into the pathophysiology so we can understand how hyperkalemia occurs. We have two homeostatic mechanisms for maintaining serum potassium. Important just to remember that potassium is the primary intracellular cation. So more than 95% of your total body potassium is actually found in the intracellular space, and it's primarily in muscle. So the serum that we are actually measuring is only about 5%. The two major homeostatic mechanisms are the first being the sodium-potassium ATPase pump, and this buffers extracellular potassium against its large intracellular pool, and is stimulated by the secretion of insulin following a meal, which then stimulates glucose uptake into the cells, and also increases the sodium-potassium ATPase activity. And then our second mechanism is urinary excretion. So normally about 90% of potassium excretion occurs in the urine, and only less than 10% through sweat or stool. And within the kidneys, potassium excretion occurs in the cortical collecting duct. You can go next. So the next important thing is to be able to differentiate between hyperkalemia, so a true hyperkalemia, or a pseudo hyperkalemia. So your pseudo hyperkalemia is most likely related to how your blood sample is drawn, how it's stored, and how long it takes to be processed. So pseudo hyperkalemia can be caused by anything that causes hemolysis, anything that causes tissue lysis, and then obviously without phlebotomy. So prolonged tourniquet use, if your patient's fist clenching, if you're taking the sample upstream of an IV line, which we shouldn't be doing, and then also things that we can't really control, like a patient who's got a thrombocytosis or leukocytosis, that also falsely elevates your serum potassium, not your plasma potassium. So most important, if you have a high potassium on your blood results that doesn't really match your clinical picture, just be sure that the sample wasn't contaminated and that it was a clean sample. If you're not sure, rather repeat that than going through and treating a hyperkalemia when you're unsure of whether it's actually pseudo or true. Okay, so we can go next. So going into true hyperkalemia, there's three different causes or main mechanisms of causes for hyperkalemia. So the first is an increase in potassium intake. So that's IV or oral potassium supplementation, or recent blood transfusion of packed red blood cells. The second is a decrease in excretion. So if you have any kidney disease, chronic or acute, that results in a decrease in your glomerular filtration rate, any adrenal insufficiency, and also many drugs, ACE inhibitors, angiotensin II blockers, spironolactone, all the potassium-sparing diuretics, actually. And then the third is a transcellular potassium shift. So the most common cause of hyperkalemia is an acidosis. So when you have an acidosis, your hydrogen ion enters the cell preferentially, resulting in a decrease in potassium uptake by the cell to maintain that electrical neutrality. So if you're gaining a positive charge with the hydrogen ion, that potassium ion is not then going to be taken up, and it's going to stay in the extracellular space and cause a hyperkalemia. So yeah, then looking at an uncontrolled type 1 diabetic, like we said, after a meal, insulin is secreted, and that actually stimulates the action of sodium potassium ATPase pump, which causes a cellular uptake of potassium. So if you have a insulin deficiency, this mechanism then doesn't actually promote the action of the sodium potassium pump. Again, here you can have drugs and toxins. A very common one we know is SUX, as well as propofol. And then very strenuous or prolonged exercise can also result in a transcellular shift and massive cell lysis. So any process that really leads to a cellular injury or death, rhabdomyolysis, like in a crush injury, or anything that causes massive hemolysis. Okay, so the next slide. So this is just looking at your different mechanisms, different drugs, and how they affect your transcellular shift and sodium potassium ATPase pump as well. Just a nice summary slide. So whenever you're not sure about a hyperkalemia, if you're thinking of causes, you've got to be thinking of the 3 different mechanisms of how a hyperkalemia is caused. The first was your increase in potassium intake, decreased secretion, or transcellular shift. And if you can think of it in that way, then you can have like a bit of a systematic approach to figuring out what is causing your hyperkalemia. Okay, we can go to the next slide. Okay, so looking into your patient history. So again, like we said, you need to be very, very sure that your blood sample was obtained correctly and always correlate it with your clinical picture. If you've got a massively high potassium and your clinical picture doesn't match at all, you need to think twice about whether this is really a true hyperkalemia. Asking about any recent blood transfusion, like we said, any red blood cells that have been transfused recently. And then looking at your risk factors for a transcellular shift. So is there an acidosis here? Are we thinking of a tissue death like a tumor lysis syndrome? Is there some kind of crush injury? And again, like we said, a lot of drugs and toxins can cause a hyperkalemia. So you need to go into that medication use, any presence of any drugs in the household, if it's a child, coming in, and you need to be sure that the adults in the house are not on any of that kind of medication that a child could have gotten their hands on. Then you're looking at urine output and fluid intake. So this can kind of give you a bit more of an idea regarding your kidney function. Then any bloody stools can explain a hemolytic uremic syndrome. Again, looking at your kidney function. And like we said, your kidney function can result in a decreased excretion of potassium, causing this massive hyperkalemia. And then again, history of trauma, burns, crush injuries. From the burns, actually mostly thermal injuries are what causes this hyperkalemia. Then going into, you can go to the next slide, going into your medical and family history. So a family history of acute or chronic renal failure, hypertension, diabetes, adrenogenital syndromes, any malignancy that could be causing an underlying tumor lysis syndrome, neuromuscular disorders, or malignant hypothermia. Okay, so you can go next slide. Then we need to look at the consequences of hyperkalemia. So when we're looking at the clinical presentation, we need to kind of understand why a patient would present this way. So what happens is when there is too much potassium outside of the cell, it increases the resting membrane potential. So what then happens is it can cause a contraction of that cell or muscle, and eventually that resting membrane potential gets so high and is above the threshold potential, which means that once your muscle depolarizes and contracts, it can't actually repolarize to allow for another contraction. So essentially what your potassium does if it's massively high on the outside of a cell, is it increases that membrane potential. So if you think of where your muscle cells sit in your body, you've got your three main cells that will be affected. So your skeletal muscles, if you think of a skeletal muscle, it can contract, but now with this massively high potassium, it's not able to repolarize and have another contraction. So that's where you get your weakness, your flaccid paralysis that starts in your lower extremities and then ascends upwards. Then you're looking at your cardiac muscle. This is the one that we most commonly see and the most dangerous consequence of hyperkalemia. And that's cardiac arrhythmias and cardiac arrest. Again, looking at your cardiac muscle not being able to repolarize and contract again. And then the final is your smooth muscle. So that's where you're going to be found. That's really found in your gastrointestinal system. And that's where you get your mild intestinal cramping. So if you can think of why hyperkalemia causes your clinical features, you think of where your different muscle groups are, it's a nice, easy way to remember your clinical presentation. If you can go next slide. If you are a fan of mnemonics, there is a nice, helpful mnemonic that we can use for the clinical presentation, the signs and symptoms. So it's murder. So muscle weakness, like we said, your skeletal muscle. Urine, you're going to have an oliguria or an anuria. That's looking more into what could be causing your hyperkalemia. Respiratory distress, decreased cardiac contractility because that muscle can't repolarize. And again, because of that cardiac muscle being affected, you will see ECG changes, which we'll go into a little bit later. And then your reflexes, so hyperreflexia or eventually areflexia. All right, so then there's also some non-specific findings like we have with most metabolic abnormalities. So you can have the fatigue, kind of like a depression, and that the nausea, vomiting, that kind of thing. Okay, you can go next. So this is just a list of your differential diagnoses that you need to consider when you're thinking of a hyperkalemia. That's pretty much looking at your causes. I'm not going to go through all of those because we've already spoken about them before, but just important to know that it is quite important to look into what is causing your hyperkalemia, as this will guide your treatment and further investigations. Okay, you can go next. So your investigations will be guided by your clinical history, your clinical presentation and your history to try and figure out what would be causing it. But in your basic investigation workup for every patient, you should be doing a gas, doesn't have to be arterial, so a gas, a UNE, and a creatinine. And then your urine dipstick, you're looking at if there's any proteins for your renal dysfunction. And of course, the most important, an ECG. So ECG is looking at your peak T waves, your lengthening and eventual disappearance of your P wave, and a widening QRS. We'll look at some examples just now. So those are your basics, and then you can go next slide. Then, like we said, the further tests will be based on your clinical suspicion. So your bloods, you can look at serum uric acid and phosphorus tests for any hemolysis syndrome. You can look at your serum creatinine phosphokinase and calcium measurements for rhabdomyolysis. An FBC, like we said, thrombocytosis and leukocytosis can cause a pseudo-hyperkalemia. And then your plasma osmolality test and drug levels for suspected toxicities. It could be any of our drug levels, but most commonly digoxin. Then for your urine, you can look at your urine myoglobulin test if you're suspecting a crush injury or rhabdomyolysis. And then your urine electrolyte tests, including a potassium and osmolality tests. So those are more based on what your clinical suspicion is. Okay, we can go next. Okay, so looking at your ECGs, this is a very, very important thing to understand and to know how to identify because your treatment is also very dependent on whether there are or are not ECG changes. So this first picture here just gives you an idea. It's a push and pull effect is the way to remember it. So hypokalemia, you're pushing down that T wave, resulting in a T wave inversion. You've got ST depression and a prominent U wave. Then in hyperkalemia, it's almost like pinching that T wave. So if you think about it, pinching it, you're pulling it up, and it results in a peak T wave. Because you are making that peak T wave, the P wave can start looking a bit flattened and ultimately disappear. And then you're looking at PR prolongation and widening QRS. So your ECG changes will also be more prominent as your severity of your hyperkalemia worsens. So initially, you might just have a peak T wave. As it worsens, you could have a wide PR, a wide QRS, and then ultimately, you will have a loss of that P wave, and it almost looks like a sinusoidal kind of wave. At that point, your serum potassium is extremely high. So for just your peak T wave, you're looking at a potassium of between 5.5 and 6.5. When you've got other features like the widening, you're looking at a 6.5 to 8. And then when you get the sinusoidal wave, you've most likely got a potassium of greater than 8. And when these T waves merge to cause a sinusoidal pattern, this is usually just before a cardiac arrest occurs. So all of these ECG changes can result in bradyarrhythmias, so your sinus bradycardias, your blocks, and even a slow AF. And also then looking at your conduction blocks, like we said, bundle branch blocks, and your fascicular blocks. Okay, then you can go next, just looking at an example of an ECG in a patient who has a hyperkalemia. So you can see it in all the leads, but if you're looking at lead 2 on our rhythm strip, you can see those very tall, symmetrically peaked T waves. But overall, you can actually see the T waves peaked in every lead. And this is very, very obviously specific of a hyperkalemia. And this is something that needs to be addressed urgently. Okay, you can go to the next slide. Okay, this is just a summary slide of what we just spoke about, explaining that the ECG changes progressively worsen as your serum potassium level rises. And like we said, by the time you've got your conduction abnormalities, your severe conduction abnormalities, you've most likely got a potassium of more than 7, and you're at a point where you peri-arrest. Okay, we can go next. So now the most important part of the talk is steps to management of hyperkalemia. And there's 4 really important things to remember when you're managing hyperkalemia. If you can remember the 4 different mechanisms, then it's easy to remember how to do it. So the first is to discontinue your precipitants. Like we said, your oral intake or IV supplements of potassium, you need to make sure that those are stopped immediately. The second is that you need to stabilize that myocardium. If you're having these ECG changes, you know that there's already myocardial compromise. So you need to stabilize this myocardium. And the way we do that is with calcium. The third is to shift your potassium. So there's lots of different methods. We can use glucose and insulin, a beta-2 agonist, and even sodium bicarb. And then the last and final is to remove the excess potassium. So that can be with loop diuretics or K-oxalate. But the most important to remember is that it's never just one of the above. You need to be thinking about all 4 of these different ways to decrease that hyperkalemia. One on its own in a lot of studies has not been proven to be nearly as effective as this almost like a multimodal approach. So the 4 steps: discontinue precipitants, stabilize your myocardium. Then you need to think of a shift and removal of your excess potassium. Okay, so the first one is obvious, to discontinue your precipitants. You can go to the next slide. The second is to stabilize your myocardium. So we talk about using calcium. You can use calcium chloride or calcium gluconate, whichever you have available. So what your calcium does is it binds to your calcium-dependent calmodulin and protein kinase 2 receptor and activates your sodium voltage gates, allowing your sodium to enter the cells and increasing that resting membrane potential. So that's what calcium does is it antagonizes the cardiac effects of hyperkalemia. It raises the cell's depolarization threshold and reduces that myocardial irritability. So like we said, hyperkalemia ultimately results in a very increased resting membrane potential. Calcium results in an increase in the cell depolarization threshold. So your myocardium and the muscle isn't as irritated and dysregulated. And ultimately, the point of the calcium is to stabilize your cardiac cell membrane against any undesirable depolarization. So yeah, increases the cell depolarization threshold and decreases your myocardial irritability. Okay, you can go next. So our third method or steps to management, is shifting. So we have 3 different mechanisms of shifting. You can use insulin and glucose. We never really ever use insulin on its own, but we will go into that. Your sodium bicarb and salbutamol, so your beta-2 agonist. And the way that all 3 of these work is by stimulating that sodium-potassium HPase pump, which would then result in your extracellular potassium being taken up into your intracellular space, decreasing your serum potassium. Okay, we can go next. So insulin and glucose, important part of our ABCDs is always DEFG. Don't ever forget your glucose. If you're thinking about shifting, you have to keep monitoring that glucose. You don't want this to be an unwanted side effect. Now that you're trying to correct a hyperkalemia, you're causing a massive hypoglycemia. So the way that insulin, like we said, insulin works is it binds and stimulates these sodium-potassium HPase pumps, moving sodium out of the cell in exchange for potassium. And the point of the glucose is not only to keep or prevent a hypoglycemia, but it also hopes to increase your endogenous insulin production. Yeah, so important. Don't ever forget glucose. And throughout your treatment and management of hyperkalemia, you have to be monitoring your glucose very carefully. Okay, next slide. So sodium bicarb, it's only indicated in a severe metabolic acidosis. So that's looking at a pH of below 7.2. Sodium bicarb is used as, we have to be very careful when you're using it. And it's in all the studies have shown that it's not effective on its own, and especially not effective in the first hour after administration. So you can't be using it on its own. It takes too long. And by the time it's kicked in, you've most likely, your cardiac active or your myocardial muscle or my myocardium is not stable, and you've already got these arrhythmias going on. Again, like we said, it stimulates the sodium potassium HPase pumps. When you're using your sodium bicarb, we know you have to watch for a hypernatremia, because these pumps are exchanging your sodium for your potassium. You can also result in a volume overload, and especially important to watch in patients with chronic renal failure with this volume overload. So again, before you're using this, you need to be looking at your gas very carefully, only to be used in severe metabolic acidosis. Okay, you can go next slide. Our third and final drug to be used to shift is salbutamol. So this is just a cycle of how it actually causes intracellular potassium uptake, but ultimately it's exactly the same as the other two, and it stimulates your sodium potassium ATPase pump. Very important, you can use salbutamol nebs or IV salbutamol, but the side effects with IV salbutamol are much more prevalent. Studies have shown that either route is equally as effective, but you need to be monitoring very, very closely if you are using IVI, especially because it can cause cardiac side effects. And this hyperkalaemia is already causing these cardiac abnormalities. So now you've given IV salbutamol, and one of the side effects can be things like tachycardias, palpitations, hypotension, and it can also result in a sympathoadrenal activation. So again, causing a tachy, your vasoconstriction, and ultimately hyperglycemia. Again, like we said, don't ever forget your glucose. It's also a tocolytic. So in our population that we are treating at Rahima, if your patient comes in labor and just so happens to have a hyperkalemia, you don't want to be using a tocolytic agent. You'd rather shift using one of the other methods, so insulin and glucose or sodium bicarb if there's a metabolic acidosis. Okay, so those are our 3 ways of shifting. We can go to the next slide. Now we're looking at elimination. So we've already said that you need to stop your potential or discontinue your precipitants. You need to stabilize their myocardium with calcium. You've got your 3 ways of shifting, and you also now need to be thinking about elimination of this excess potassium. So one of the ways we use is K-oxalate. There are actually no clinical studies looking at this, looking specifically at the efficacy of K-oxalate in the management of hyperkalemia, but it's thought to bind potassium in the intestinal lumen and prevent it from being absorbed into the gastrointestinal tract. So it's then promoting its excretion in the stool. Again, important to remember, this is not something you use in isolation. You shouldn't be using any of these in isolation. Okay, next. Your next is your loop diuretics. So the way your loop diuretics work is they inhibit the sodium transporter and increases distal sodium delivery that results in potassium secretion into the lumen. So evidence for the use of this in acute management of hyperkalemia is very lacking. So again, this is only suggested as an adjunct. And very, very careful to note the known adverse effects of loop diuretics. So ototoxicity, hypotension, a lot of electrolyte imbalances like a hyponatremia, and then obviously your hypersensitivity reactions. So again, an adjunct, not a definitive treatment method. Okay, you can go next. So this is hemodialysis, our only definitive and most effective treatment that we have. It is indicated in severe hyperkalemia, extremely effective, and very, very important to know that this should be available and when to refer. Okay, so we can go on to the next slide. Now, before we get into treatment, we know what we need to do. We need to know when we should treat and what to look out for. So for the grading of hyperkalemia, you've got mild, which is more than 5.5, moderate, which is more than 6, and severe, which is more than 6.5. So in severe, you've got 2 different subcategories, one without ECG changes and then one with ECG changes, which is very important to remember when you are treating. Okay, the next slide. So we're going to start with treatment in adults. It's a very wordy slide, so I will just summarize it and go into the key points here. So this is where the grading comes into play. So for your mild, you can think about just using your adjuncts like K-oxalate and your loop diuretics to increase excretion. This is something that can be done in a ward. It's not necessarily something that needs to be done urgently, but does need to be monitored very closely. Then you're looking at your moderate, so more than 6. You need to think about shifting at this point. So shifting, like we said, there are 3 different ways to shift. You've got your glucose and insulin, you've got your salbutamol, and then you've got your sodium bicarb. So when you're looking at moderate, you wanting to use your glucose and your insulin. Remember to be giving that glucose before you're giving your insulin, and to give them in separate IV lines. And you must always monitor, like we said, don't ever forget glucose every hour for at least 6 hours after you've given that glucose and insulin. And then, like we said, you can use your adjuncts, so your K-oxalate and furosemide, to increase your elimination, and dialysis if available and if needed. Then we're going on to our severe. So we start without ECG changes. So without ECG changes, you can give nebulized salbutamol. And we don't really use the IV salbutamol as much in adults. So nebulized salbutamol, very quick onset of action, very effective. And then, like we said, glucose and insulin. If you're having that metabolic acidosis, you use sodium bicarb. And then your adjuncts or increased elimination, K-oxalate and dialysis. Then when you're looking at severe and you have ECG changes, as soon as you have ECG changes, you need to stabilize that myocardium. That is your number 1 priority. So you can give your calcium chloride, 10 mils, and you need to be sure, if you have given or are planning to give sodium bicarb, it needs to be in a separate IV line, because otherwise it will precipitate. Then again, your glucose and insulin, salbutamol, and then your increased eliminations. So that's looking more at treatment in adults. And always remember to check your ECG before you start your treatment. Okay, then going on to treatment in children. This is the protocol from our hyperkalaemia protocol that we use in Rahima. So we're just going to break it down and go through it quickly. So the first one, stop all sources of potassium, recheck it, and increase fluids. So like we said, make sure it's not a pseudo hyperkalemia. So recheck that potassium if you're unsure. And 2, discontinue your precipitants. Then you're going to be looking at how high is this potassium. So like we've said about the grading, more than 6.5 is very severe. You need to be taking to resus, placing on monitors, and you need that ECG. On your ECG, you're looking for your peaked T waves, any flattened P waves, your PR interval widening, wide QRSs, and your arrhythmias. And you're looking at your clinical signs like we discussed, looking at wherever your different muscle groups are, skeletal, smooth, and cardiac. You're looking at your weakness, paralysis, your abnormal arrhythmias, and your intestinal cramping, nausea, and vomiting. Okay, you can go to the next slide. So step 1 in our treatment algorithm is your beta-2 agonist, your salbutamol. Again, remember, if you have ECG changes, you need to be ready to give this calcium gluconate. The reason we have nebulized salbutamol as step 1 is because it's something quick that you can do while the calcium gluconate is being drawn up, and while you're getting IV access. The nebulized salbutamol can just be popped on the kid while you're doing and preparing for your IV access. So your salbutamol, then your calcium gluconate. Your step 3 will be your loop diuretic or furosemide. Always remember to check the rest of your gas before you start giving your loop diuretics. You need to be sure that there's no hyponatremia, because remember, that's how we actually exchange potassium for sodium. And then step 4, you're looking at your insulin with glucose. So that's very important. Like we said, it's always insulin with glucose, never just insulin. So to remember at this point, always check your HGTs. Yes, okay, so you can go to the next slide. Okay, step 5 is your sodium bicarb. This is only to be used if there's a severe acidosis. So if the pH is less than 7.2, that's when you consider sodium bicarb. And like we said, it buffers that hydrogen ion concentration, resulting in an increase in pH and shifting that potassium. To remember to always check your blood gas for hypernatremia, hypocalcemia, and clinically also for a volume overload, especially in our patients who have or are suspected of having renal failure. Okay, then going on to step 6. This is your K-oxalate, like we said, an adjunct, not definitive treatment, and definitely not to be used alone. It's something that could be started in the ward. It's not something that has to be done in your ED setting unless your child is there for an extended period of time. And then throughout all of your steps, to remember to check that potassium level hourly, and don't ever forget your glucose. So you're going to check your potassium levels and your glucose levels until your potassium is less than 6, and your glucose, if you have used insulin and glucose, for at least 6 hours. Once you've gone through all of your steps, if there's no response, you need to be discussing with the referral center. In our setting, if we have a hyperkalemia or severe hyperkalemia, once we've started these steps, we will be discussing or have discussed already with the pediatric reg on call, just to be sure that they are on board with us. Because after all of our steps, if there's no response, an insulin glucose infusion needs to be considered. But don't ever start this without discussing first. And your glucose has to be monitored every 20 minutes if you're doing an infusion. Okay, you can go next slide. All right, so this is our overall algorithm that we just went through now. It's a really great algorithm, but you need to be aware of what you're doing and why you are doing each of the steps. And you need to be sure that you are looking for your other electrolyte abnormalities. Don't just get hyper-focused on correcting this hyperkalemia when you could be causing fatal other electrolyte abnormalities as you go along. So again, you can go to the next slide. If you like mnemonics, there is a mnemonic for helping us treat hyperkalemia. So it's C big K drop. So C is for calcium gluconate, B is for your beta-2 agonist, so your salbutamol, insulin and glucose, like we explained, your K-oxalate as an adjunct, and then drop is for your diuretics and dialysis. If you can't, mnemonics are great, but it is difficult to remember all of the different mnemonics. So if we can just go back to the slide, slide 20. Let me just check, sorry. Slide 17, Dr. Stanton, where it says step to management. If you struggle to remember the mnemonics, it is important, a few more. There we go, that's the one. So if you struggle with the mnemonics, the most important things are to remember the 4 things you need to be doing to treat this hyperkalemia. So number 1, discontinue your precipitants. Number 2 is stabilize your myocardium with calcium. Number 3, shift. Your shifting mechanisms are glucose and insulin, your beta-2 agonist, and your sodium bicarb. Sodium bicarb only if your pH is less than 7.2. And then your removal or elimination of potassium. Like we said, none of these should be done in isolation. It is a multimodal approach. In our protocol, although stabilizing the myocardium is obviously the priority, while you're doing IV access, to remember you can put on nebulized salbutamol. It's quick, easy, and the studies have shown equally as effective as IV salbutamol. And also to always remember to check that ECG. If you have ECG changes, you know which algorithm to follow, and the most important thing to do is your stabilization of your myocardium. So yes, I think that's it. So we've covered all the different causes, the ways to remember your management. If anyone has any questions, welcome to ask, but that's the end of my hyperkalemia talk.
Thank you, Jessie. That was awesome. I have two questions for you.
Sure.
What other kind of dialysis method is there apart from hemodialysis?
So you can do, if I'm not mistaken, you can do peritoneal dialysis.
Yes, and that very well
Yes.
might be used in lower
Yes.
resource environments or for chronic management,
Yes.
and particularly in kids. I know we used a fair amount of it in KZN, so it obviously depends on the patient and where you're working. But dialysis is an option. It isn't just hemodialysis.
Okay.
Okay. Other question. What are your cautions when using a diuretic with hyperkalemia?
So when you are using your diuretic, you need to be checking your gas like we have with all the others, but important to check your blood pressure. With the loop diuretics, you're also going to be increasing your fluid excretion. So you could ultimately cause a hypovolemia. So you need to be checking your patient's blood pressure, and you need to be checking for any hyponatremia, because the method of these loop diuretics is to use the sodium potassium chloride co-transporter.
Sure.
So with it
So
taking, when it takes potassium into the cell, it's also taking the sodium. So if you already have a hyponatremia, it could worsen your hyponatremia.
So even simpler,
Yeah.
before you use a diuretic for your chronic management in the ward, make sure that your patient is actually able to pass urine. So if your patient is anuric and not passing urine, don't give them a diuretic.
Okay.
So if they're an anuric patient, otherwise you're going to potentially have the side effects with none of the benefits.
Okay.
Any other questions?
Sorry, there was one last thing I wanted to just remind everyone, is to always calculate your corrected potassium. So in our patients who have a severe metabolic acidosis, you're anticipating your potassium to be high. So you need to be aware, and you need to calculate your corrected potassium before you now go and treat a hyperkalemia when it actually isn't above 5.5, or it isn't above our threshold for treatment. So the way you taught us, Dr. Stanton, was for every 0.1 change in your pH. So your normal pH, we take as 7.4. So every 0.1 decrease in that pH will be a 0.3 decrease in your potassium. So for example, if you have a pH of 7.2 and you have a potassium of 6, that 7.2 is 2 jumps away from 7.4, which means you need to be minusing 0.6 from your potassium, and that'll give you your corrected potassium. So that'll give you a potassium of 5.4, and your treatment might be a bit different for that. Just to remember that.
Cool. So to remember, every 0.1 change in your pH, you expect a 0.3 change if we're being cautious in potassium. Some texts use 0.5 as the correction factor. So if you are acidotic, your pH is down, you expect your pH to go up. Likewise, if you're alkalemic, you expect the potassium to go down. It works both ways.
Yeah.
So if you've got a severe acidosis, you probably will have what looks like a hyperkalemia, but it is probably a pseudohyponatremia. Just always look at your ECG to see if there are features. Okay, cool. Thank you very much.
Perfect. Thank you so much.
Any other